I just want to say thank you from Mayo Clinic and from our entire team for being here tonight. After a long pandemic, to be able to be together, it's joyful. Even if we are together because of a common bond that maybe wasn't so joyful. So thank you for being here, and for those of you who are online. I'm joined today by Dr. Marysia, who is my partner in crime, and also with Sue Milbrandt, who is our study coordinator for our research for our Mayo Clinic SCAD registry, as well as Dr. Rekha Mankad, who directs our Women's Heart Clinic, and our SCAD clinic comes up under the Women's Heart Clinic at Mayo Clinic. And from Mayo Clinic, which you can see up on the slide, those are the Mayo brothers, but I would say your Mayo sisters appreciate everything that you have done to be the wind beneath our wings in order to be able to pursue this research. We always think that we are never going as fast, finding findings fast enough, finding things that will affect individual patients quickly enough, and answering your questions and our questions fast enough. So know that the support that SCAD Research Inc. and all of those who've donated and all of those who have participated in a SCADaddle, virtually or in person, has been the way that we have been able to see a path forward, and that we are committed to continuing to do that. Tonight, we'd like to share a few of the findings to assure you that despite the pandemic, we have not been sitting on our heels. We have really been working, despite taking care of a lot of patients, cardiac and COVID and everything at Mayo Clinic and elsewhere. So tonight we'd like to celebrate the progress that's been made, the people who have helped us do that, and to share a little bit of a few updates, perhaps, of what we're doing, and then to take some questions at the end. But before we start on our formal presentation, I would like to take just a moment of silence, because we know that not everyone is a SCAD survivor. And I'd like to just take a moment of silence for those who we have lost to SCAD. All right. So tonight, I took this from one of my t-shirts. You can ask me about SCAD, and you can ask Dr. Tweet too. So I don't want to take for granted. I know everyone in the room is pretty familiar with the SCAD because I've said hi to everybody, but I want to make sure that those of you who are watching afterwards know that's what SCAD is. So when we talk about heart attacks, a heart attack is when the heart muscle does not get an adequate blood supply for any reason. A SCAD heart attack is when there is a separation between the heart, the layers of the heart arteries that then obstructs the blood flow. And what it isn't is what you see on the far right, atherosclerosis, where there's a fixed blockage. And I think it's important when you look at this picture that you see that's a tear, that's a bruise, intramural hematoma, and important to know that that might heal. And I want to talk about, just at a baseline, what we are doing in our research. These are our overarching goals. This is not just the two of us up here, but we want to make sure that we increase the knowledge, but also to share the knowledge with other folks. Because we know everybody doesn't come to Mayo Clinic. They have doctors all over the place. So we want to make sure that cardiologists, emergency medical technicians, emergency doctors all know. So we're looking at designing and conducting research. We want to use data. It's really important that we present at scientific meetings. I'm giving you some background because all of you support research. So one of the ways that academic cardiologists, or academics, is we take our work, we take our findings, and we then present them to our colleagues and our peers. And our peers poke holes in that. They say, I don't believe that. I think your methods are flawed. Wow, that is an interesting observation. And that's really important because we get that feedback from people outside of our group. Same thing, we publish in peer-reviewed journals. And I will say that this week, I think, Dr. Tweet, I saw at least 3 new publications submitted. Now, submitted doesn't mean published. It means that that journal will take it. They will send our work out to 3, 4 other people who are experts in the field, and they will give us feedback, and they'll say, we don't believe that. You did not support your data. Or, wow, that's a cool finding. And they will make our work better as we go back. And that's been we network and we share on social media, so follow us. I think importantly, because remember, when I went to cardiology school, I did not learn about SCAD, or what I learned about SCAD was I might see 1 or 2 in my career. Okay, that was wrong. So we're engaging. I think I saw 3 yesterday. But so what we're doing is trying to engage our trainees so the future of cardiology, the future of healthcare, will care for this illness in a better way and will look at it differently. We collaborate with others, and one of the things I really want to share is because of the strength of the support from SCAD Research Inc. over time, we have been able to build the largest biobank of DNA from SCAD patients and their parents of anyone in the world. And as a result, we've been able to contribute that DNA to international studies. And we'll talk about that a little bit later. But I think that collaboration is really important because everyone brings something different to the table. So we want to fill the knowledge gaps and improve the diagnosis, the clinical care at every level, whether you live in a tiny little town, or you live in Manhattan, or Rochester, Minnesota. We want the care to be better. And ultimately, can we figure out how to prevent it? Can we figure out how to predict it? Those are the goals, and we're not there yet. So here's some throwback pictures I will show. There's some throwbacks of both of us and Bob, who visited Mayo Clinic. But as we talk about the team that puts this together and how important that is, I will say the upper left-hand corner picture when Dr. Tweet is pregnant with one of her. Number two. She has 5, okay? That's how long we have been in this business. So, yes.
He's 10 now.
He's 10 now, okay? So we're committed to this on a sustained basis.
He's here, too.
Yeah, he's here, up in the hotel room. Come up closer so they can hear you. So, and this, I wanted to show you. You don't have to read the words, but this is the very first poster. I will just tell you, for those of you, it sounds like poster. Why would you do a poster? Well, at medical meetings, at academic meetings, the first way we present our new science is often in an abstract form, and then if our abstract seems interesting to that meeting, then they say, will you present a poster? And the poster is and so this is that first poster, Dr. Tweet's first author, where she put together just the story of how we started our research. You want to share that?
Yes, so Dr. Hayes, Sharon, but I'm being pulled back into my training now. When I was a resident in training, and I sought out Dr. Hayes for mentorship at that time, and had asked for projects, so we were working on some projects together, and then we met in her office to just touch base, see how things were going. I think I was on a CCU rotation at the time.
She was very busy.
Very busy, and she said, hey, do you want to help me with this project on SCAD? And she told me a little bit about it. I was young in training, internal medicine residency. I wasn't even in fellowship yet. I wasn't even sure I was going to be a cardiologist yet. And I said, sure, thinking it would be a 1-year project, abstract, done, over, move on with life.
Yeah, I will take some credit for it. My side of the story is I knew that this would be, I had worked with her, and she's fantastic. And I thought, this is going to be a lot of work, but I cannot think of another person I would want to work with this on, because we need the creativity. How do we take a rare, what had been at that time described as a rare condition for which we only had access to patients through social media and an online presence, and how do we make this a legitimate scientific study?
Yeah, so we worked together, did this as a pilot, and we did it with 12 patients because I went to a course, and they said 12 is a good number to start with. So I was like, okay, 12 it is.
Yeah.
But it turned into something much greater than anticipated, and I am so grateful I said yes, because it has shaped my career.
So we published this first patient, and we had to go through a couple of review processes because they said, 12 patients, that doesn't tell us anything about SCAD. Right, I agree with that. The largest published series at that time was 40 patients, 42 or 3. So 12 doesn't add much. But the way that we put together the methods maybe was. Now, we were fortunate in that we actually, it was a very interesting story. The Wall Street Journal, kind of at the time we published this, lifted it up. At the time we said, wow, we'd be really lucky if we got 100 patients in this registry. Mm-hmm. Well, I'm going to spare you the suspense. We're well over 1,500 at this point. But this was back in 2011. This is our very first publication. I flash forward because I wanted to share with you some of the important impact for which SCAD Research Inc. really helped us. Well, one is this scientific statement. So when patients say, my doctor said, I knew nothing about SCAD, or they had a misconception about SCAD, one of the things we really felt was important is putting in the hands of the doctors who are caring for patients a scientific statement. And to come out in Circulation, which is the major journal of the American Heart Association, that was very important. And then we followed up with a state-of-the-art review in the other major journal for cardiologists. And you can see there are multiple authors. That's on purpose. This is not supposed to be a Mayo thing. We wanted a consensus from people who are all over. So we really have made an effort to engage partners. But you may have thought we were not working during the pandemic. And I'm just gonna flip through because we've had multiple publications in 2020, 2021, and then we keep going. We're engaging our radiologists here. 2021, 2022, 2022. So I want to make the commitment to everyone in this room and who's online that we continue to look for ways that we can use the data that we are collecting as well as collaborating with those across the world, honestly. But let's get back to the patient. So SCAD's a heart attack. SCAD affects women predominantly, about 90%. And we know it is still, despite the efforts that we've made and you've made, is under-recognized. And I think that's really our mission, is to, advance the science. How are we going to treat it? How are we going to prevent it? How are we going to make the patients who are presenting today are properly managed? So just some background. A lot of you know this, but I don't want to take for granted. So the average age of SCAD patients is young. Younger women, 42 to 52. That average age keeps rising, and I think because we are recognizing that some of those older women that we were calling just regular heart attacks because they were older may have are more likely to have SCAD. And so we are seeing that average age rise. It is predominantly women, but men get SCAD too. And if we think of women with SCAD being kind of rare, the man with SCAD, I think we have even more to learn about, and they need to be a part of the research. About 5 to 15% are recently pregnant or pregnant, and that's an important part, but that actually is the ones we've known the most about. There's no SCAD gene, and I think that's important. There isn't something we can go and test, but at the end of this, toward the end, we're going to talk a little bit about some of the future of SCAD. And we used to say cardiovascular risks like hypertension and hyperlipidemia and smoking were absent. But actually, we found that hypertension or high blood pressure is probably about the same as the general population. It is lower than those who have the regular type of heart attack, but it's not absent. And it's important because controlling blood pressure in patients after SCAD is really, really important. And it's not rare. We were just missing it. It's an important cause of heart attack in women under the age of 50 and women who are pregnant. This study was published just this year. Now this, I'll let you tell a little bit about this story.
Well, you can fill it in, but Alexis Johnson is one of the best medical students I've ever worked with, and she approached us wanting to help with our research, and she is currently a resident in emergency medicine out on the West Coast. And I think she's had 2 publications that she's first author on that have been through the peer review process and entered the academic literature. And she, among other trainees we work with. But I take such pride and joy because she is an example, among others, where we see the trickle-down effect, where we're engaging medical students who maybe don't even go into cardiology, but are becoming their own experts in SCAD and are becoming local experts and going on to residency and sharing their knowledge with other trainees and other disciplines even. So she did some fantastic work and is just a wonderful person as well.
Yeah, so she started as a first-year medical student at Mayo Clinic and continues to engage with us now as a almost second-year emergency department. And so in this study, we really wanted to understand what are the symptoms that women come in with, why are they being missed? And I think the important thing out of it is over 80% of women who are SCAD patients who come in with heart attacks say they have some type of chest symptom. So this is not an atypical presentation. I don't like the word atypical because that often means that the man was the typical or it's the atypical patient. It's the 30-year-old who has classic heart attack symptoms. And about 20% don't have that first troponin that is elevated. And that was important because there's a real push in emergency departments to risk stratify. And they use a lot of things like cholesterol and smoking and all of this. And they say, and if that first troponin is negative, maybe that puts them even lower risk. And I think one of the cautionary things of this particular paper was you need to at least get a second one. Because it's important, because if a fifth of the individuals are going to come in, you don't want to send them home. And I think that's the important message after this paper. So the symptoms of SCAD are heart attack symptoms. They are chest pain, they are shortness of breath, they are radiating pain up to the jaw or neck, back. They're the classic heart attack symptoms. STEMI, ST, elevation, myocardial infarction, is the most serious type of heart attack, and that's the most common. About 15% will present with cardiac arrest or ventricular fibrillation, and about a quarter will have more than one artery affected at the beginning. And a trigger, emotional stress, physical stress, will be presented by 20 to 30, maybe up to 40%, depends on the study. One of the things that really has come out is that immediately trying to stent that vessel may cause harm in SCAD patients, which it may not. And we know that the other good thing about SCAD, compared to the other type of heart attack, atherosclerosis, is it often heals. So this is that bright light, is that this is something, if you can get through that early part, that you might be able to have an artery that is open and looks pretty normal. So when we think about SCAD, because every patient I have ever taken, why did this happen to me? What is the cause? That is the Holy Grail. Well, no, actually the Holy Grail is how do we detect it and prevent it. But if you think about the sort of conceptualizing this, it is the vulnerable patient. So it's that individual who may have fragile arteries. They may have something else that's going on, and then emotional stress or something comes on top of it. Physical stress comes on top of it. I will just say that in the majority of patients, there isn't a single issue that we can say, oh, that's why you had SCAD. But we'll talk about some of the other causes later. Some of the things that are associated with SCAD, not cause, but migraines seem to be more common in patients with SCAD. That's also a vascular issue. So we talked about pregnancy being a risk time. Elevated blood pressure may be, but the vast majority of patients have what we call a systemic arteriopathy. And basically what that means is SCAD doesn't just happen in the coronary arteries. They may show abnormalities in other blood vessels. And we'll talk about later why it's important to screen for that over time. The most common is fibromuscular dysplasia. Some of you have been told, oh, like you understand that there's some type of type. So Dr. Saw at Vancouver and colleagues described type 1, type 2, type 3, type 4 of SCAD. I think it's important to note that this has been very helpful to cardiologists who are looking at angiograms. But it isn't important in terms of having had a SCAD 3 or 4 months later. I have patients who say, what type did I have? Type 1 is the type we've always been taught to look for. It has a flap. We see it on the angiogram. Type 2 and 3 are both intramural hematoma. And what that means is there's a bleed between the layers of the blood vessel, but it doesn't cause that blood vessel to split. And actually, it's those people that we now know we should worry about the most because they may be at somewhat higher risk of extending and having an earlier extension of heart attack. So we sort of talk to cardiologists, okay, it's important to know, to recognize it, to say, oh yeah, that's a type 1 or type 2. But that you say, oh, we have an intimal flap or we have intramural hematoma. That's probably more important from a physiologic standpoint. And I know none of you are going to read angiograms, but this is what it shows. So you see that you see how this artery here is kind of wide, and then it gets narrower, and then it goes bigger. That's not normal. Arteries in general get big and gradually smaller as they go down the tree. So we know something's abnormal there. And there we actually see a flap because you see kind of this, it's a little hard with the projection, but you can see that's sort of a disruption. Both of those are SCAD, so that's important. We also have other tools. And the one thing I'll say is one of these on the left is intravascular ultrasound. The other is optical coherence tomography. Both are things that are done at the time of an angiogram. Okay? Some people ask, well, can they do that? But that's actually a catheter that they put in the artery. So when we talk about to cardiologists in general, what are we thinking? So beta blockers have been associated in observational trials with maybe lower risk of recurrent SCAD, but treating blood pressure is really important. If we think these are people with a vulnerable artery, the most vigorous thing, the most stress that artery has is every beat of the blood pressure, right? And so lowering blood pressure, normalizing blood pressure, we think will help. We don't use statins routinely unless people have high cholesterol. There aren't any other SCAD-specific drugs unless you have heart failure, depression, or chest pain. We do recommend generally that patients who are on oral contraceptives or postmenopausal hormone therapy, that they would stop that, and that they would stop triptan medications for their migraines, because those are drugs that cause the blood vessels to constrict. We don't want that after SCAD. I'll let you talk about other things that we do after SCAD.
So I'll go ahead and talk about this slide. So we think about this arteriopathy when we're trying to better understand why SCAD occurs. One of the findings coming out of this research, both at Mayo Clinic, but also found elsewhere, and essentially we've been validating each other at these different centers that are studying SCAD, is that fibromuscular dysplasia, as well as other arterial abnormalities such as dissection or aneurysms, are incredibly common among SCAD patients. And so currently in clinical practice, and this is a consensus-based recommendation that's in that AHA document that Dr. Hayes showed you earlier, was to do at least a one-time imaging of the arterial beds that we think are most pertinent to know in terms of the anatomy. So that is the head, neck, abdomen, pelvis. So at Mayo Clinic, we actually have a dedicated scan the radiologist made just for SCAD patients. We call it the SCAD protocol. And as mentioned here in this slide, it is not just to rule out FMD, but rather it is to better assess the arteries elsewhere and ensure that there's nothing else that needs monitoring, such as an important aneurysm in the brain. And also, I do think for some patients it gives some closure in terms of understanding the disease. It's helpful for us both as clinicians and researchers. And there is a lot more work to be done, obviously. But the more pieces of information as we try to solve the mystery of SCAD, the better, and this can be incredibly helpful. The other thing that is not on this slide, but I've observed in general, and Dr. Hayes has noticed this too, is there is not a whole lot of plaque or atherosclerosis. So I make it my habit to always look through these images and take a moment to look for even plaque or cholesterol or calcium, and it's very uncommon in patients with SCAD, which is consistent with the observation that patients often don't have high cholesterol or other atherosclerosis in their arteries of the coronaries. So again, as we try to piece together why, and as we better understand why, get better at determining how we may prevent or predict, hopefully we'll continue to make progress.
I think one thing that has become a shortcut for cardiologists and sometimes for patients, they come in and say, do I have FMD? I've read about that's associated. I will just say that we don't believe that currently available, even at Mayo Clinic, scans can rule out FMD. That's not the reason we do this scan. We want to make sure that there aren't dissections or aneurysms in other parts of the body that need treatment or follow-up, because we have had a few patients that had clear FMD, say in their arms. We look at their scan and it's completely normal. So FMD we think is kind of it's probably in all of our arteries, but it may only show up in a few. And CT may not be sensitive enough. So that's important. I don't tell patients anymore. Maybe I did 6 or 7 years ago. I said, oh, good news, you don't have FMD. And now that we found these patients who may have it, or we know that our tests are imperfect. So I think the important thing is, yay, I don't have an aneurysm. Yay, I don't have any other dissection. That's the important thing. And if there is FMD found, it's generally mild, and the advice is the same. Let's get a low blood pressure. Let's treat you prospectively over time. So you want to talk about a little bit about pregnancy?
Sure, absolutely. And I'll add one more thing about FMD is before we learned about the association of SCAD and FMD, there is a whole entire realm of research focused on FMD before SCAD even became a hot topic, so to speak. And it's great because we've opened our horizons and have collaborated with those researchers as well, and have noted that there's much more overlap even when it comes to the genetic piece than we previously would have realized. But moving on to pregnancy, pregnancy-associated SCAD is of high interest. As you saw with the statistics, I think at first people thought a lot of SCAD was pregnancy-associated, but as we acquire more participants, we're seeing that actually is a smaller sector, and really a topic that needs further study, because we have found that these patients present quite severely. They tend to be quite sick when they come with multiple vessels involved with the SCAD. And there's some other observations that help us try to hypothesize, again, mechanisms for SCAD. Observations such as an advanced maternal age, having multiple pregnancies or a history of multiple pregnancies. And then we have a lot of ongoing hypotheses about infertility versus infertility treatment, preeclampsia, eclampsia, and continue to focus on that. But also, I was mentioning to someone earlier tonight, differentiating what is perhaps different than the woman who had SCAD postpartum than the women who had maybe 4 or 5 children and didn't have their SCAD till they were postmenopausal. And are those mechanisms different? And I think there's a lot of questions in that regard, because again, one of the focuses of the research is to better understand the why, so that we can take it a step forward in regards to then the prevention. If you understand what's going on, you're much better to treating and preventing.
Well, because of these sobering statistics about SCAD being more serious or associated with pregnancy, we generally tell or advise patients who've had a SCAD not to have a pregnancy. And as you may have heard me say before, that may not be the worst news to the 45-year-old woman with 3 children whose family was complete in their mind, compared to the 20-year-old college student who doesn't yet have a boyfriend, right? The implications are quite different. And so it's been of great interest to understand, okay, if you decide to go forward with a pregnancy, I'm just going to say our advice is still to avoid pregnancy because it is a high-risk time. But both leading with Dr. Tweet, as well as a recent publication from our British colleagues, we know that most women will tolerate a pregnancy after SCAD. But there is a significant, kind of 8 to 12% who will not. And so we've shifted a little bit where we talk about, yes, we advise against pregnancy, but we will work with that individual to understand their desires, to help them understand to the best that we can their risks in pursuing that. Because I have patients who say, 12% risk? Absolutely not. I have a child. I would not want to leave them motherless. And others who would say, I so want to have a baby. That's so important. That is a risk that I am willing to take. And I think really important, rather than listening to dogma, is trying to get the data through research to better advise individuals who are making these tough decisions. But I want the message is, we think the safest course for a woman after SCAD is not to have a baby. But we really do want you to exercise, okay? For your bones, for your heart, and we do know that certain patients have been told to do nothing. And one of the things we know from our data, from others, is to tell that 30 or 40-year-old woman, like, just don't do anything, don't lift anything over 10 pounds. I worry when she approaches 60, 70, 80, she's going to be this willow of a thing with breaking bones who falls over, breaks her hip, and dies from a broken hip. So what we want to have people do is stay healthy, 30 to 40 minutes of moderate intensity exercise, stay fit, stay strong, but don't do things that are at the extreme. And we'll be the first to admit to say this is with an abundance of caution, because we know that some SCADs have been associated with high intensity exercise, or perhaps even with an uptick. I want to get in shape. I haven't been, and they spend 4 to 6 weeks getting in shape. That doesn't mean all of them are happened. So, but we do want people to exercise. We want you to be strong, do some resistance training. We also don't want you to lift things that require you to hold your breath. Okay? For most women, that is between 20 and 50 pounds. So you can gauge that. So we don't give a weight limit per se. If you can lift something and breathe, it's probably fine. And for most people, that doesn't mean anything, any limitation. However, there are certain professions that require heavy lifting, and some people may like lifting boulders in their backyard, or they like moving furniture, and we do advise against that, and endurance training. But what we really want people to do is stay fit, because if you have been my patient, you know I say you need to live life like you will never have another SCAD, but also be prepared for that possibility. And that means staying fit and strong. I don't know if you have anything else.
Nope, nothing else to add.
So we want to shift gears, because one of the exciting things I think for us is the role of genetics in SCAD. For those of you who are part of our SCAD research, you may have been asked to give a little DNA as part of the research. We're particularly interested in people where we have, early on we were collecting the parents' DNA, and we tested some of that. And one of the things we discovered really early is there is no SCAD gene, there is no FMD gene, because we did whole exome sequencing on family members and did not find any common gene. It would be great if we had a gene test that we could say, oh, you have it or you don't. So when we think about that, and this is just like genetics 101, there are certain abnormalities like cystic fibrosis or Marfan syndrome, where there's a single gene mutation, and we test for that. And if you have it, you have the disease. And if you don't, you don't. So we know that SCAD, there isn't a single gene. For a lot of conditions, particularly even atherosclerosis, there's lots of genes that have been shown to be at risk. And if you have a lot of those genes, or one of the high-risk genes, you're more likely to get that. And if you don't have many of those genes. So again, it's sort of a polygenic condition. And we're looking at SCAD being much more that polygenic look. So SCAD's probably in between, but probably more on the right, where there isn't a single gene, it's multiple genes. There's sort of two types of gene testing that we do. One is whole exome sequencing, and that's where we actually look at every gene for an individual. We look at every single one. The other is we take at least 100, maybe 500 genes, and we look across the genome-wide association. Both are very important, but we've been involved in both of those. So the Mayo Clinic SCAD GWAS study has allowed us, and I will say this has been predominantly funded by SCAD Research Inc. We can thank this organization and events like this who have helped propel this. So we've been able to analyze, do genome-wide association testing on the vast majority of our samples. What that has allowed us is, one, some discoveries, but also to push forward and contribute our DNA to some of these international consortiums that are then able to build on Australia and Europe and other parts of the US and Canada, and where else? New York and Michigan and England and France. So we pool our resources, which just makes it stronger. And what's important, I think, for you to know is, because we have the largest DNA biobank at this point, we are very sought after in order to contribute to these big organizations. One of the early ones, and this was published in a couple of years ago, and the co-first author, one of them was Dr. Olson, who retired from Mayo Clinic but was kind of our guiding star for our genetics. And what we found is there is a gene, and if you have one allele, so if you have one part of it, you're more likely to be a woman with SCAD and FMD. And if you have the other, so the alternate, you're more likely to be a man with atherosclerosis. So that was very intriguing. It may mean that people with SCAD may be at lower risk of developing plaque in the future. This is yet to be confirmed, but our hope is that maybe in 5 years, we may be able to do a polygenic risk score. And we have that for certain conditions, where we do a gene panel and we can say, oh, you have 5 of the genes that have been involved with SCAD, so you are at middle risk. Oh, you have 10, you're at higher risk, and your children might be at higher risk. Oh, you only have 1, and maybe your children would be at lower risk. This is not clinically available. I want to say that. This is not a test that we can do now, but this is part of the research that we are looking toward the future. So we now have, remember I said we thought it would be a dream to have 100 people. We have over 1,500, and again, our study coordinator who helps us every day, Sue over there, has helped us reach those milestones. We look at the imaging, the coronary angiograms, anything else. We take, for those of you who are participants, you know that we may ask you questions. We ask for a bunch of data and then we keep asking you. That's very valuable for you to respond. And we follow up, and people who actually come to Mayo Clinic and are seen in the SCAD clinic, we obviously gain some additional data. Our current team, this is the core team. So it's us, it's Dr. Best and Dr. Galati, both interventional cardiologists. You may have seen their name on some of your charts if you're a patient, and they interpret the angiograms. Dr. Olson, who recently retired. But honestly, if I had the full list, we've got radiologists and geneticists and lots of trainees who are very interested in Mayo Clinic on doing this work. So we will stop here and take questions from the room, and if there are any questions online, we're happy to take those as well. Oh, got it. We'll repeat it too for the audience. So,
can you talk a little bit more about the infertility portion of women that you're finding SCAD? I was one of your patients, because I was great. And I had issues with infertility, had a baby with help from the fertility clinic, that was fine. And then it was when I had a natural pregnancy that my SCAD occurred. So I'm curious to just hear more about what the infertility portion.
well, you know, way back when we thought, you know, okay, SCAD predominantly occurs in women. So the answer was about what do we know about the relationship possibly to infertility and SCAD? And way back we thought, oh, maybe infertility treatment was a risk factor. But some of the women who were having SCAD, it was 10 years after their infertility treatment. So we started thinking, is it infertility treatment, which often requires hormones, Or might there be some common link between infertility and SCAD? I don't think we have an answer to that yet in terms of that, but I think we don't want to just say, oh, getting Clomid or one of the drugs for infertility puts you at risk, because it may be that there's some common mechanism. And that happens in a lot of conditions where you first see an association and then you say, yeah, but is it really the drug, or is it the condition that was being treated by the drug that is more a concern?
Well, and the other thing I will add to that caught our interest is when we were doing some of the work on pregnancy-associated SCAD and looked at, because it's included in the questionnaires, looked at details about infertility and so forth, the percentage or prevalence of patients who reported infertility, and we pooled a lot of them together. So, those who received treatment versus not, seem to be higher than what's reported in the literature for the common, general population of women. So that caught our attention. It merits further study. It's actually very difficult to study, but definitely something that we incorporate when we are proposing projects or thinking about the next steps.
So a lot of times these are trends. So we ask you guys, for those of you who are part of the research, we ask you literally hundreds of questions. And it was a little bit of a scatter because these were one or two SCAD patients who said, I had X, is that associated? So we then asked a large number of individuals and try to piece that together. It does appear that infertility is more common in patients with SCAD. It appears that migraine headaches are more prominent in SCAD, which is several things. One, migraine, we need to figure that out, but also treatment of migraine sometimes is complicated by some of the drugs we cardiologists use as well. So,
and also nuances of registry versus population-based data. So our work focuses a lot on the registry, but we also do work with the Olmsted County Rochester Epidemiology Project to get population-based data for SCAD too. So our publications are a combination of registry as well as population-based in kind of the interaction, along with collaboration with other projects. So if you look at the publications that have come out of our group, you'll see a wide variety from observational to actually we're working on prospective, as well as registry-based, population-based, and collaborative.
So one of the criticisms that legitimately you can make for a registry like Mayo's is that it's biased in some way. So it's biased because we're a tertiary referral center. So people who do great may never come to Mayo, right? They have one SCAD, it's minor, they're never diagnosed, they're not part of our research, right? So that's one. The other might be that, okay, you're not capturing everyone. Okay, this started on a heart disease in women online community. Maybe we're missing a lot of men, right? Because we started out with women and maybe there are men with SCAD that we are undercounting. And there is some suggestion from some other registries that we might be, that there should be more men in our registries. So I think all of those, we are not here to say that the Mayo Clinic SCAD registry is the be-all end-all. Actually, the be-all end-all in some ways would be being able to do randomized controlled trials and having enough data. There is just for your information, there is a randomized controlled trial that's being just started in Europe that's going to be looking at, and when I say randomized controlled trial, what that means is you take a group that is very similar to another group and you treat one group differently and you see what their outcomes are. And so they're looking at beta blocker versus no, and dual antiplatelet therapy, so aspirin plus clopidogrel versus aspirin alone. I think that will be if successful, now one of the concerns we have is, will they get enough patients in it to be successful? But it's all of us working together across the globe that's going to answer these questions, because as much as we are saying, yes, this is a more common condition than we thought it was, it is still a relatively uncommon condition that's not easy to study.
The other thing I'll add about research is you're always looking and then re-looking. So I personally don't assume that once we do a paper or a project on a topic that that's the end. And maybe 5-10 years you look again and make sure that it's consistent and you see what others are publishing and see if they're aligning or if they're different, and if they're different, why. And that's the part of the process of research. So it's a continual learning process, which is why I'm probably still doing it, because it's exciting in some ways, and you see the fruits of the labor over time. But I'm also careful about premature closure on anything, because if you don't keep somewhat of an open mind or perspective, or try every so often to think outside the box, or maybe think of something that might sound crazy at first, but if you pause, or bounce the idea among others, you know, the list of that core group of Dr. Best and Galati, I mean, I can't tell you how many times, along with you, Dr. Hayes, and others, that we're bouncing ideas off each other. What are we missing? What are we not thinking about? What do you think of this? I saw this patient. This seemed a little unusual, constantly. And that gives us that intellectual motivation, but also that helps promote and inspire the progress of the research itself.
See ya.
So, I think I saw on the slide that you were recommending arterial scan as something to do, maybe for, if I understand it right, for someone who's had a SCAD in the past. And so my question would be, you know, I think the fear of reoccurrence for someone who's had it, is that what you recommend? Is that like probably the best thing that a SCAD patient can do to try to just kind of, I guess, gives reassurance that they're doing okay?
So the question, I will repeat the question. So the question is, okay, we talk about doing the body scan, the arterial scan, but is that in any way reassuring about recurrence? And I would say no. I think the one-time scan is to make sure we don't have something else we need to look for other than the SCAD. SCAD recurrence right now is relatively unpredictable. In none of the studies that have been done, and we've kind of looked at and compared the European, the Canadian, the Mayo group, if you add them all up, if you sort of average them out, it's about 2 to 3% per year. It's been pretty consistent. Now, there's a little bright light in a recent Canadian prospective. It was a bit lower, and that was a group that a lot of them took beta blockers. But I would just say that right now we're really early in being able to predict, oh, you have a low risk versus a high risk, and we should treat you this way. And so that risk stratification, that's what that's called, being able to tell an individual, are you higher or lower risk, is a little elusive at this time because of numbers in all of these registries. And the main reason for that one-time scan is not predictive of future SCAD, but more, do you have an artery to your spleen that has an aneurysm that we should look at next year? Or do you have a brain aneurysm that we should deal with now? And for the most part, we don't see serious illnesses, but that's why we do the scan.
And when we do the research, we do include that data when we're trying to look for prognostic components. So we're constantly including those details as well as other studies. That's definitely a thing. But I just want to add something for perspective. Our publication in 2012, we talked about patients who had another SCAD in that specific manuscript. Before that project, there was really, I would say, nothing in the literature that talked about SCAD happening again. And rather, patients were being told it's a fluke, go live your life, it'll never happen again. So 2012 is when our paper was published talking a bit about that. So if you think about that, it's 2022, that's a decade, 10 years, for a complex disease process that perhaps has more than one mechanism to occurring, and that isn't a single gene mutation. So there's a lot of work to be done, but we've already learned a lot within the past decade or so. And if you look at publications in the literature in a common database called PubMed, you look back and you just put in the keyword SCAD, and you look how many publications there are per year. The number of publications are exponential. You can actually fit a curve to it. And that just shows you the interest in the scientific community, and in part because of research support, patient participation, social media, our abilities to diagnose it better, our abilities to disseminate the knowledge and have others interested in the topic, as well as encouraging trainees to learn more. I think that all accelerates the process, but there's a lot of work, and if you think about it compared to a lot of other diseases, we're still early in our understanding.
I just like to tell patient groups, because they say doctor didn't know about this, but SCAD has been a board question on cardiology boards the past few years. That means that newly minted, like I'm taking a test so I can be a board certified cardiologist, and they're being tested on SCAD. That's big. Like, it is felt like this is important enough.
I have to tell you a story. When I was a fellow in cardiology, one of my co-fellows came up to me and he said, Marysia, I think I had one of the questions they're testing, because when they test questions to use in the real exam, they'll ask it like 3 different ways through the test. And he's like, it was on SCAD.
And now we have heard from our fellows that they had and if they're at Mayo, they've learned all about SCAD, so they nail that one. There's a question way in the back.
Thank you for speaking today, and thank you for the care you provide to these specialties. My question is, I noticed on your list that there didn't include aspirin or any antibiotics. Could you elaborate on that and your thoughts on that?
Sure. So, first of all, so if you conceptualize SCAD, it's more of a bleeding event. If you think about, it's a split in the blood vessel, it is a bleed within the layers of the blood vessel. If we think about plaque, which is where most of the recommendations for taking antiplatelet agents like aspirin and clopidogrel or ticagrelor or even heparin early on, those are clotting events. That's a plaque rupture for which a blood clot forms on top of that and clogs up an artery. So 2 completely different. But largely, SCAD patients early on are treated very much like a clotting patient. It is our recommendation and our practice is if once we make the diagnosis of SCAD in the hospital, we stop the anticoagulants, we stop the heparin and the blood thinners. There's a lot of lack of consensus on whether we continue like things like aspirin and clopidogrel, the dual antiplatelet therapy. So the guidelines would say, I have a person with a regular heart attack, I'm gonna, even if I don't put a stent in, I'm gonna put them on aspirin and clopidogrel, or Plavix is the common name, for a year after they have a heart attack. There are some studies that have suggested that people with SCAD who get both of those drugs may do worse than those who get only aspirin, which is starting to make cardiologists rethink. Now, I think that if you asked 100 cardiologists how they treat even people who are familiar with SCAD, most would still say, you know what, I would feel most comfortable sending that patient out of the hospital with aspirin, maybe even clopidogrel for a month. But I think there's no evidence of benefit, and there's a potential harm in having that dual antiplatelet therapy for long term for that year. So my own practice, and I will let Dr. Tweet weigh in because again, this is still not guided by a lot of research, is if I see a patient who's out of the hospital after SCAD who's on both aspirin and clopidogrel, I stop the clopidogrel at the moment. Could be 2 weeks, could be 2 months, could be 2 years. I say, like, stop that. There's no need, and in fact, there may be some risk. Whereas aspirin, I'm starting to de-prescribe at about a year. I will just preface this by, it's really hard for cardiologists not to send a patient after a heart attack out with nothing. I would, what is your practice? My
practice isn't too different, but I want to emphasize the caveat that I do treat my patients who had stents placed differently.
Yes.
So that's very important. So for those who've had stents, I continue the aspirin and Plavix for a year together and aspirin lifelong. I commonly still have many of my SCAD patients continue baby aspirin if they're not having difficulties, but if there are problems, whether it be gastritis or intolerance or bleeding or what have you, I have a low threshold to stop it. But then I also consider other potential indications where those medications could be useful. So some persons may be prone to clot in the left ventricle depending on where the damage of their heart attack was. Others may have profound, diffuse fibromuscular dysplasia, in which case I'd be a little more biased towards continuing aspirin and so forth. So it's very much a patient-by-patient basis. So the reason why you may hear different practices is because there's really very minimal data on what to do. And our goal is to change that headed forward, and that's the goal of many. But that is why you'll hear different things, and a lot of this is consensus-based or based on observational data that we have and expertise.
So one thing that has been observed in at least 3 studies is that those individuals, when they come in with their SCAD heart attack, and the angiogram shows intramural hematoma, so like that bleed within the walls of the blood vessel without a flap, those are the individuals who, one, tend to have the early extension, perhaps more bleeding into that cavity that then blocks the blood vessel. And it appears that those individuals who also get both aspirin plus clopidogrel, or one of the other drugs, may make them even more likely to extend that heart attack. So I think we need to confirm those data. I will say that if I've got a patient who's been on aspirin for years, they don't have a stent, and they say, "Doc, can I stop aspirin?" I would say there's not a good physiologic reason at that point to prevent SCAD or prevent a heart attack for me to do it. And I'm having an individual conversation with them and often stopping the aspirin. Based on recent data, so some of you may have seen, it was kind of big news about the U.S. Preventive Task Force. Now that was for people who never had a heart attack, preventive aspirin, and basically they came out and said virtually no one really qualifies unless they're at very high risk for developing plaque. So diabetics, high blood pressure, very high cholesterol. I kind of put SCAD patients into that primary prevention. They don't have plaque, they don't have high cholesterol, they don't have diabetes often. And so using a number of different data points is how we are making those decisions. But again,
and it's changing. I mean, one of the studies that Dr. Hayes just mentioned was a study just published in the fall of 2021. So I know that I might be saying something different now to my patients that I visited with 3 or 5 years ago, and it will continue to change and evolve over time.
We have several questions from the Facebook live stream. One of them is there any research on SCAD post-COVID?
so I think the SCAD post-COVID research is going to take a little time to understand. So there have been reports in the literature of SCAD related to COVID infection, not maybe related, but around the time of COVID infection. There have been case reports of SCAD happening around COVID vaccination. I think we have to be really careful to kind of put those together. Obviously, that very, very sick SCAD patient who's in the hospital in the ICU, that is a stressor we might say might be appropriate for SCAD. But particularly for an infection that has infected literally millions of people and hundreds of millions of people having gotten the vaccine, and with SCAD having a baseline prevalence, whether they are associated at all, we don't know. And I think we have to be really careful. And one of the things I've said when people have asked about safety of vaccines, I've said, like, certainly severe COVID infection would put you at much higher potential risk of having a SCAD than the vaccine. So we're encouraging vaccines in patients who have had SCAD in the past or are concerned about it. And even if there's some temporal relationship, I don't think we can make that. And that's going to be probably something that in a couple of years we'll look back, we'll put all the data together and see, was there a higher risk? So certainly, theoretically, a very severe COVID infection could lead to SCAD, and there have been case reports of associations, or at least around the time, and whether they were causal. That's the big question that we always have to answer.
And then we have Sarah's project too.
Yeah.
And if I mention
Yeah,
it.
go ahead.
So we have a medical student at Mayo, Arizona, who is very much interested in this, and early on the pandemic, she created a survey that we sent out to our participants, and we had a very good response, and she's put together that data, really asking questions about the effects of the COVID-19 pandemic on patients, whether it be them being sick and how sick they became, how it affected their livelihood and so forth. So she is presenting a poster. She actually had 2 abstracts accepted, and we're working on the manuscript to submit as well. So that is an ongoing project, perhaps a little different than what was asked, but it certainly is something that we're also looking at.
Because we know that COVID-19 affected all of us, our psyche, our physical health, and so trying to understand the unique effects, potentially unique effects on patients who have had a SCAD is also really important. Do you have another question?
Is a heart cath the only way to detect a SCAD?
That is considered the gold standard and the perhaps most direct, highest resolution, reliable way of detecting a SCAD and diagnosing it. Cardiac CT would be the next on the list, particularly for, as the technology improves, we're getting better, and for SCAD involving the larger vessels. The challenge with CT is when you get to more distal vessels, your resolution is not as good, and we have seen situations where the SCAD diagnosis is overlooked. And then other cardiac imaging modalities such as MRI or echo, they can indirectly tell us of whether or not we should suspect a SCAD, but really the best way of knowing is looking at the anatomy, which is generally an invasive coronary angiogram. Non-invasive would be the CT coronary angiogram with some limitations in regards to how reliable that is. But it is getting better, and our radiologists are getting better at identifying it.
I think it's important that there are ways to say, yes, this patient had a heart attack. Because MRI, echo, CT, enzymes, troponin, can tell us this patient had a heart attack. And what I think is really important is we know why that heart attack happened. If it was a plaque rupture, Dr. Tweet and I are going to go all in on statins, on antiplatelet agents, and prevention of development of future plaque. And if it's SCAD, we're going to take a slightly different tack in terms of prevention. And so really, coronary angiogram is the best currently. CT coronary angiogram is helpful but cannot be relied upon. And other testing can tell us, yes, you had a heart attack, but not why. Any other question?
Is there a medication other than metoprolol that can give desired results without causing fatigue?
So one study has shown that the use of beta blockers, of which metoprolol is one of them, but there are a number in that class, has been associated with a lower risk of recurrence, and also it lowers blood pressure, because the other risk of recurrence is people who have high blood pressure. So hypertension has been a risk for increased risk for a recurrent SCAD. And there are many types of beta blockers that are available, some of which are less associated with fatigue, and so it is reasonable to try one of those, bisoprolol, carvedilol, there's a number of them. So I recommend that patients talk to their doctors, because I do think we lean toward, until we have evidence to the contrary, that it's probably best, at least in the first year, to be on a beta blocker. But, and beta blockers can cause fatigue, but they get blamed for fatigue, all drugs, because you're taking them. Having a heart attack can make you fatigued. And so it's often human nature to blame something you're putting into your body when it's not, and often when we stop the medication, the fatigue or whatever symptom does not improve. So that's another caveat. I'm not saying it never causes fatigue, but honestly, I think that trying to stop it, switch to a different one, but having a heart attack, the few months afterwards, many patients feel fatigued regardless of what drugs or not they are on.
And I'll also add, beta blockers are a mainstay therapy for heart attacks of all causes, for a lot of reasons that have been well studied, and hence the reason why we even are more compelled to continue them early on at least.
They stabilize rhythm, they decrease the work of the heart muscle, so that and they have been shown to improve survival, which is why cardiologists kind of like them.
And there's a gentleman who has raised his hand several times over there.
Okay.
Thank you. If I can move back to the stents issue, one of the slides you had said stents may cause harm. So my question is, what are these potential harms, and are they like short-term or longer-term concerns for harm?
Great question. So one of the things, and it was one of Dr. Tweet's earliest observations in one of the earliest publications where she was first author, was we recognized, and around the same time the Canadian group, is SCAD patients who got stented had about a 66%, so 2/3 of a success rate for the stenting, whereas somebody coming in with a regular heart attack is like 95%. So why is that? So when we go in and look at an artery, it's technically more difficult to put a stent in a SCAD artery. The artery is more fragile. We might not be able to get in the right, if there's a flap, we might get that stent or the wire that we use in the wrong place. Or we may cause some damage to the already damaged vet and end up, instead of putting one stent in, we end up with 4 stents or more. So we recognize pretty early that maybe stenting is more risky. And then we correlate that with the fact that a lot of these arteries are going to heal on their own. So that led to a general approach where if we can get away without stenting, we try to do that. We can't always do that. There are patients who have major blockage of blood flow to a major area of the heart, and we have to get it open, right? We have patients who are having ongoing chest pain for days, and we have to get it open. So this is not to say you should not stent, but we do selective stenting if a patient is stable, if they're not having a heart pain. Let's watch them for a little bit and see if they need a stent, because we know that the technical aspect of stenting in SCAD patients may be a bit more fraught. Does that answer your question?
Yeah, so I hear
That's the short term. Yeah, and so there are long-term consequences of stents in any patients. So stents are a permanent part of the body. That's a question sometimes, well, will they take it out or will it go? So stents go in your body, they stay there. And modern stents tend to stay open, but there's still a risk of what we call restenosis. And scar tissue can build up inside the stents, and that can happen to anyone, regardless of the reason for the stents. So if we don't have to subject a patient to that long-term risk, because the artery would heal anyway, we also want to try that. But we don't spend a lot of time questioning the decisions made at the time of the heart attack, right? Because if they recognize it's SCAD, but they also recognize this is a patient who really needs that blood flow improved, it is a rock in the hard place. We know that it's going to be a harder procedure, but they need it.
We have a couple questions related to stents here as well. Can you have a dissection again in a vessel that has been stented?
Okay. So what we know is that having a bypass graft or having a stent put in doesn't protect you from future SCAD. And that's another reason why we might not rush to put a stent in. Because on average, most SCADs occur in a different vessel than the original one. If you're going to have another SCAD, say the most common vessel is the left anterior descending, or LAD. If you have that kind of SCAD, it's more likely that if you were to have another one, that it might be in a different vessel. So I think the question being is, yes, it's theoretically potential, but putting a stent in one artery doesn't mean you're free of a future risk, and that's probably important. So it's a reason not to put a stent in, just to protect from the future.
There's another question here about stents. If you've had stents put in several years ago for SCAD, can they be removed, and does the stent cause the artery to heal? I'm not sure.
So that goes back to my last answer, is that stents are part of your body. Once they're in, they are part of you. They tend to get a layer of cells over them, and so they don't come out. And it is late, and I think we will, if there are maybe one more question, or we wrap up now, because for those of you who are going on a 5K in the morning, we want to make sure that you get plenty of rest to do that. Is there anything else from online? I see a question here.
Yes, I was wondering if you do any other interventions that don't involve drugs, because you're like, since stress is such a big part of this, like, are you prescribing meditation or other things that you know help to prevent the hypertension or whatever?
Yeah, so great question. So the question is, are there non-drug, non-pharmacologic therapies that we prescribe or we think that are important? So the first right out of is cardiac rehabilitation. So somebody has a heart attack, and often women and younger people or people who look healthy are less likely to get that referral. So that's one thing we really advocate for, because cardiac rehabilitation has been proven to reduce death and reinfarction and hospitalization. And it includes not only getting physically active, but mentally back where you need to be. Do we recommend, I routinely recommend stress reduction. I talk about yoga, mind-body type things, mindfulness, meditation, and other things, which also might include counseling, depending on what the stressors are. So the short answer is yes, but I wanted to put a plug in for cardiac rehabilitation.
Similar answer. I've referred some patients to our health anxiety clinic because that seems to help the health-related anxiety. We do have a study, actually the first project that Alexis Johnson or Dr. Johnson worked on was looking at depression, anxiety, PTSD, and other measures, and we found that patients with high resiliency scores tended to score lower for measures of anxiety and depression and higher on measures for quality of life. So measures that are focused on resiliency are important. For those who have a component of trauma from this event or coupled with other traumas in the past, we have found patients who have benefited from PTSD-focused, trauma-focused therapies. Now, proving that those prevent additional SCAD is a whole nother challenge.
But we think that it's good for people in general if you have anxiety, depression, PTSD, getting that treated, and all of us could learn to manage stress better. Yeah, I'm just saying. I'm just saying that would be good for all of us. So thank you very much. I don't know if any of the